Jensen. I'm a board certified family physician. We do this every Saturday at 9 a.m. Central and every Sunday at 10 a.m. Central, where you have the opportunity to ask your questions and hopefully get an answer. This is Tucker. He is my co-host from heaven, and I appreciate his help. So that is it for the introductions. We are live on Instagram and YouTube. So you guys can let me know where you're listening from, what city, what state, what country. Somebody yesterday requested that we talk a little bit about bundle branch blocks, intense exercise, endurance exercise. And also, I want to just touch on a newer class of medications that is coming out for cholesterol. So, let me see. Somebody is listening from Ajax. I'm not familiar with Ajax. Ajax what? Okay, where are you guys listening from? What city, what state, what country? I would appreciate it. Let me know. It's always fascinating who I have on. Glasgow, Scotland. What time is it there? Pintock, what time is it there? Canada. Yeah, I don't know much about Canada, Jeanette, but thank you for listening. We have Las Vegas. Buckingham is from Las Vegas. Mary is listening from the UK. Jeanette, again, is listening from Ontario. It's in Scotland. It's 4 p.m., so it is 10 a.m. here in Iowa. I'm located in the middle of Iowa, in the middle of the United States. So glad that you guys are here. Galloway, New Jersey. It's 11 a.m. Yeah, you guys are an hour ahead. Yeah. Okay. Mary's in England. It's 4 p.m. there. So same as Scotland. Arizona Nana is listening from Tennessee. She is biking. Maybe we're going to talk about that today, Nana. How far are you biking? How long do you bike? Do you bike every day? Are you at risk for the athlete's paradox? That's what we're going to talk a little bit about today. Maybe you don't want to listen, so you don't know. I don't know, but it's just something that came up yesterday. I can't remember who brought it up. Maybe it was Coach talking about triglycerides. And then another young lady was wanting to hear more about bundle branch blocks. Lisa is listening from New Jersey. Thank you. So we'll get started here. I thought we would just maybe jump into this slowly and see if there were any questions to just start it out. Let everybody get involved. It's really hot here. Today is going to be the hottest day of the season. We have, and maybe in Canada they have this too, I'm not sure, but we have a feels like temperature. We used to call it the heat index, just like we would say in the winter, it would be called the, what was it called? Oh my goodness. See, I'm all into summer right now. We used to call it the heat index, but now it's the feels like temperature. Wind chill. They don't call it the wind chill anymore. They call it something else. Maybe they call it feels like temperature in the winter too. I can't remember. Nonetheless, it is supposed to be 117 today, heat index. Right now, right now is better than earlier this morning. You can barely breathe. I mean, it's like you're choking on the air. It's so thick. But I walked. I did my thing, and I'm not one to complain, but all right. Yeah, wind chill. Thank you. Mary says, I've just started resistance training with a personal trainer. It's tough, especially as I'm in my 60s. You'll get it. Just start slow and make it fun. If it's not fun, then then you won't continuously do it. And you really, you know what, you need to build muscle. Muscle is the organ of longevity, and it's very important that you do resistance training. You need to build muscle. As you know, your personal trainer is probably said that to you. So you guys over on YouTube, please hit the thumbs up. Let's start by talking a little bit about the electrical system. The electrical system in our heart. We have I call it an electrical system, and we have a plumbing system. I am family practice. I am not a cardiologist, but this should be almost common knowledge for every doctor. So I'm not giving you any information that you could not look up being a non-physician. But we're just going to briefly touch on it because I think it's important, especially when talking about the athlete's paradox or age by, in and of itself. The electrical system is the wiring. And there are two things that a listener brought up yesterday in regards to bundle branch blocks. There's a right bundle branch block and there's a left bundle branch block. So what you really want to think about is a highway, and you have a right lane and a left lane, depending on which lane you're going to. So you have a right heart and a left heart. A right bundle branch block is on the right side of the heart, and it is a block. So that means that there is a delay or blockage in the right highway to the right ventricle. It is common in long-term chronic endurance athletes because the right atrium gets stretched out over time. It gets stretched out because of all of the volume of blood and the pressure of the blood in that part of the heart. So it stretches it out. Does stretching occur without being an athlete? Yes. Over time, if you have high blood pressure, it can stretch that right atrium. And when it does that, it can elongate or change the electrical conduction. And so it gets off. It's either delayed or it's blocked entirely. And that obviously is not good, but a right side, especially right side bundle branch block, especially in an athlete, could be a compensatory mechanism. But over time, as I've talked to you before, it can lead to conduction problems and lead to atrial fibrillation, which is, again, not good. It can also mess with the pacemaker cells in that right atrium, in the SA node, okay? In the SA node. So when we lose pacemaker cells, we lose the ability for the heart to pace itself. Your heart rate can drop down to very low levels. Okay, I've seen athletes in the 30s and 40s. Imagine how low it's going when you're sleeping. Yeah, Mad Medic says it's ablation time. Or maybe it's not. I mean, seriously, what if we don't catch this until later? And that's why it's very important to know what your heart rate is when you're sleeping, or getting a Holter monitor. If you're standing up, you're getting dizzy, you're having little lightheaded moments during the day, you really need to talk to your doctor and not just blame it on, oh, I'm dehydrated or I'm low in salt or whatever. That, you guys, don't wait. Just get it looked into. If you wear a Holter monitor for a week and it'll determine your rhythms over time, it's so simple to wear a little EKG box for a week and just know what's going on. Because if you are an athlete, okay, and an endurance athlete, you are over time, hi Habanero, over time you are getting, your heart is getting thicker. It's getting more fibrotic. And we call that cardio or cardiac fibrosis. And that, again, can lead to a dangerous scenario. Your heart needs to be very flexible, very muscular, and athletic. But over time, it gets hard and scarred, and it doesn't function very well. Just like a liver that's being choked out by fat, it gets fibrotic. Well, the heart can get fibrotic too, and that we need to know that. And your heart rate's one of the first things that will show that. Okay, that basically is the right bundle branch block, and for the most part, can be said that it's benign, with a gentle benign. I don't want you to think that, oh, I got a right bundle branch block, I'm okay. Maybe not. All right. There's a left bundle branch block. A left bundle branch block is down the left highway, and it delays or blocks conduction to the left ventricle. This is not normal physiologic response to exercise, okay? Like a right bundle branch block in a endurance athlete. This is indicating that there is an underlying pathology going on, whether it's high blood pressure, coronary artery disease, a cardiomyopathy, like a dilated cardiomyopathy. What are some other things that it can indicate? Coronary artery disease is one of the biggest ones. But again, that is a very late finding, and you would hope that you have looked into it before you have a left bundle branch block telling you something's going on. Okay. Let me see if there's any questions. All right. You guys are going to have to help me out here over on YouTube. Lucy had a busy weekend ahead, and she wasn't sure she could be here. Lucy is my moderator, my blue shield, my blue wrencher, who helps kind of monitor what is going on over on YouTube. On Instagram, we don't need that kind of stuff. If you are on YouTube right now, can you hit that thumbs up? Let's try to get up to 10. I would appreciate it. So the left bundle branch block is signaling pathology. It needs to be looked into. A lot of times we pick this up on when you guys come in for a pre-op history and physical, you're getting ready for a surgery or something, you might not have any symptoms or not notice that you have the symptoms, okay? And we do an EKG because that's required prior to your surgery. And we find that you have some underlying condition. The EKG doesn't indicate that you had a heart attack by any means, but it might indicate that you have a right bundle branch block or a left bundle branch block. And then we, doctors, the family practice or your primary care physician, would essentially not okay your surgery and ask for cardiac clearance. So we would refer you to cardiology, where they would identify your bundle branch block and make sure you are okay to go to surgery. Because when you're going to surgery, that is a risk factor. You're being put under, you got anesthesia or whatever it is. But yeah, that's a lot of times how we find these bundle branch blocks. Occasionally I will hear something like a murmur or even radiation into the neck, or I will hear a little, not a lub-dub, like you guys understand that a heart rate goes bump, 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 bump. They call it lub-dub, lub-dub. And a lot of times it will be bump, 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 bump. That is irregularly irregular. If it went bump, 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 that is regularly irregular. So the irregularity is regular. It's happening in sequence, whereas an irregularly irregular is all over the board. That's fibrillation, where the atrium is going bump, 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 bump. It's like spasming, okay? And when it's not going boom, boom, it's actually stalling the blood in the atrium, and then that can clot. And then when it does push out blood, it can cause or push out a blood clot. And yes, it could cause a stroke or a heart attack or, yeah, dangerous. And again, a lot of times people are asymptomatic or they've lived with it so long, they think it's normal. And yeah, all right. So there is a reason why we have wellness exams. But again, the minute you go to a wellness exam and you get labs or you get tested, you're going to get a diagnosis. If you get a diagnostic test, you're going to get a diagnosis. I'm not distracting you guys from all going to a wellness exam. A lot of you will get money toward, reduction in your insurance premiums. And I think I'm all for it. And as for myself, from a preventative standpoint, I could pick up things that we could probably help you with, unless, if you've let it go too long. So we talked a little bit about right bundle branch blocks, left bundle branch blocks. I now want to maybe shift gears and talk a little bit in conjunction with that right bundle branch block and athletes, is something called the athlete's paradox. Not only are these athletes, these endurance athletes, prone to conduction problems, electrical problems, they're also prone to plumbing problems. And maybe the plumbing problem is not really a problem, okay? What I'm talking about is that because of endurance athletes and they're under chronic pressure and chronic blood volume being pushed past arteries, it causes irritation and it causes inflammation, and therefore it causes an area that can form plaque. Now, the difference in the plaque of an endurance athlete and the difference of a plaque in a metabolic sick person is totally different. The plaque that's in an athletic endurance athlete is very stable, it's very hard, it's very calcified. And the risks of that breaking or rupturing is minimal. It's less. I don't want to say it's minimal, because that's a word that says, well, I'm fine. I got big giant coronary plaques and I'm fine. I didn't say that. I'm just talking about the difference in the plaque of an athlete compared to the plaque of a metabolic diseased person. The metabolically diseased person is at much, much higher risk of a heart attack due to plumbing than the endurance athlete. In addition, the endurance athlete is building lots of collateral flow to feed the heart, meaning it branches out tiny little arteries. In addition, it's like a tree branch growing and sprouting out. That's what an endurance athlete's heart would look like. Yes, they have the main arteries, the right coronary, the left anterior descending, the circumflex. They have those, but then they also have these little tributaries, or collateral flow, we call them, okay? And, that is helpful. And for the most part, these endurance athletes do not have the typical type of heart attack where you have blood being blocked, because they have these collateral flows. But what happens because of their endurance athletes that I mentioned before is, from chronic volume and chronic pressure in the heart, they develop conduction problems. Their electrical system goes bad. So again, when you look at the calcium score of these endurance athletes, it could be well over 100, 200, 300, 500, okay? And that scares many doctors, primary care included, and they send them to cardiologists. And then the cardiologists say, oh my gosh, you got a 500 calcium score, we better do an angiogram. And then they that person ends up on an operating table getting a cabbage when they might not have needed it in the first place. More damaging, I think, is getting a cardiac MRI, okay, or a CT flow rate, and making sure that everything's going well, because their likelihood of having a heart attack is conduction. They're going to pass out and go into VFib or VTAC. That's the danger. And so usually a sports cardiologist is really good. So if you are an endurance athlete, I would not see just a general cardiologist. I would send you to a sports cardiologist who's very well versed in, plaquing in an athlete, the athlete's paradox, and cardiac fibrosis, hardening of the heart muscle due to chronic volume and pressure from an endurance athlete. Different things, okay? Different things. Habanero says, I told my provider I am a carnivore and I will not be going on a statin and I will not be changing my ways. I was an endurance athlete, no longer. So Habanero, it sounds like you have, enough education that you are, able to make your own decisions. And hopefully that's called informed consent. I want each of you, that's why I do all of this, is so you have informed consent, meaning you have enough information that you can make a good decision for yourself. When a doctor is very one-sided and they would take Habanero's blood work and say, your LDL's over 130, I want you to be on a statin, Habanero would say, you know what? I've reviewed this. My HDL is elevated, my over 70, my triglycerides are less than 70. I don't have any small dense LDLs. I don't have chest pain. I sleep fine. My insulin level is 5. My CRP is less than 1. All of these things build or paint a picture for Habanero to make good decisions. And that's what I want you guys to be able to do. Have enough information. You can still get opinions and advice. I'm not saying that, but instead of just saying, oh my gosh, my doctor recommended a statin, I better just jump on it. Why? What is your diagnosis? We need to know a diagnosis before you just say, everybody's standard of care, LDL less than or greater than 130 requires a statin. You're a diabetic, statin. That's standard of care. But nobody has been told their diagnosis. All they get told is, you have high cholesterol. Well, high cholesterol from what? Do I have an overproduction problem of cholesterol? Do I eat too much cholesterol? Doubtful, but that's just one. Do I have a liver receptor problem? Maybe I don't have enough doors on my liver to take up all of the LDL that is in my bloodstream. Maybe I have an LDL receptor problem on my liver. Maybe I don't have an LDL receptor problem. The LDL gets back to the liver, and then the liver decides, hey, I'm gonna have you're gonna get rid, we're gonna recycle some of these LDLs, I'm gonna use them, or we're just gonna get rid of them out into the bowel movement via bile. Well, maybe you have a gut that reabsorbs the stuff that should have been going out in a bowel movement. So your gut puts it back into the bloodstream. So LDL looks higher. We need to know what the diagnosis is before you go taking a medication, because if you have an absorption problem that you should be getting rid of the cholesterol in your bowel movement, well, you don't give a statin for that. You'll take a statin, your cholesterol will never go down because your problem is in your gut. So you take a gut medicine. Does that make sense, you guys? We need information before we just jump into things, all right? Make sure I don't... All right. Yes, this is for medical questions only. So if you have a question, go ahead and put a Q in front of it so I know that you have a question that's medically related. Because I'm going to take my time here. I'm going to do my own little moderating. Okay. Coach says, at the end of the day, most providers just want to get you hooked on big pharma. Okay, so let me take a step back. Doctors, you're giving doctors way too much credit. They don't think about getting you hooked on anything. They don't care about big pharma. They actually just care about themselves. They care that they don't get sued. They might have a belief that coach needs a medication. They might fire you because you don't comply. And the only reason they would fire you is because if you don't take their medication, it could look bad on them, and they could get reprimanded by the insurance companies for not putting you on so-and-so medication. Therefore, doctors will put in their patient declines taking statin, despite my encouraging them to take it due to an elevated LDL cholesterol over 130, family history, ApoB over blah, 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 history of elevated blood sugars, and they will document all of these things, okay? They do not, at the end of the day, want to get you hooked on pharma. I mean, I'm speaking for myself, and I know a lot of doctors. That would be giving them way too much credit of thinking, okay? They don't think about pharma. They might think about the coffee that they're going to get bought by the drug rep who comes in, and you're having, I can't wake up kind of a day. But they don't think about getting people hooked on anything. Okay. Do most providers hold stock in the pharmaceutical companies? Absolutely. Just like any other. If you own the Dow, if you own the S&P 500, any type of ETF, you're going to own pharmaceutical. You just will. It is a big entity when you are investing in your money in finances. So not only just doctors, but lawyers and garbage people and hairstylists and everybody else. I'm just trying to put this in perspective, okay? Most everybody, if they're investing in the market, are going to hold stock in pharmaceutical companies. Now, if you think that you're going to get bought out by the pharmaceutical rep coming in and buying you a soda every day, it's possible you could be influenced because you just love soda that much, and you could be influenced to write their medication. But they don't think that they're going to hook you on anything. That doesn't even cross their mind unless they're putting you on some sort of Valium or, another benzodiazepine. Then they think, oh my gosh, I could hook them. I'm not going to give it, or I'm going to give you a pain pill. Doctors don't think like that. They're not going to put you on something that you're going to hook you. Okay. They write prescriptions like for Novo Nordisk. Of course they do. Novo Nordisk comes into the office once a week. They'll bring you a little bag of M&Ms and a soda and a coffee, and they'll tell you all the good things about their Novo products, whether it's the insulin or the Ozempics, Wegovy's, or the oral medication. I can't even remember the name now. But yeah, that's their job. They're salespeople. You don't have to let them in at all. You're not required to let pharmaceutical reps in. A lot of doctors maintain a lot of friendships with pharmaceutical reps. Over time, you're practicing for 20, 25 years, 30 years, whatever. The same reps are calling on you. You're friends. You're actually going to the fair with them sometimes. That stuff is normal, okay? But it might influence the doctor to write their product versus Mounjaro. That's a possibility. But overall, the doctor thinks, hey, I think this patient needs a GLP. And then when they think about the GLP, they're going to think about, do I go with or Ozempic, or do I go with Trulicity, or do I go with Victoza or Mounjaro? Those are the things that go through their head, and they'll say, oh gosh, I'm going to give, how would they even do this? I'm going to do Novo Nordisk this time. That's what they think, okay? And honestly, if you can go to the public there are public websites that give all the prescription history, okay? You can look this stuff up. You can actually look up how much money is being spent on that doctor over time. So over a year's time, but it's usually 2-3 years old. You'll see doctors that make 20 grand in a year. And you say, oh my gosh, that's a lot of pop and coffee. Yeah, yes, it is. However, they are actually speakers for those pharmaceutical companies. You can be a speaker for Novo, and the reps invite a bunch of doctors, and then you're paid to be the speaker, and you go through their slideshow. So the doctor studies the slides and then goes through those slides and teaches the underlings, the other doctors who come and have a steak or some fish or whatever the thing is. But every time you accept that, anything that gets in, it is under what we call the Sunshine Act. It goes under your name. Even if they bought it for your nurse or your clinic. That money, it's not just yours, your clinic goes down into it, okay? Kashua just donated to my fundraiser. Thank you so much, Kashua. I appreciate that. My fundraiser is live right now on rescue, rehab, and rehome. So I do appreciate that, you guys. That's where I got tallow and Buddy Blue. Anyway, back to the pharmaceuticals and, we going for supper, or the rep brings in a luncheon, that whole luncheon. So if you have a big giant clinic and there's 5 doctors, then that $500 of food is split between those doctors. 100, 100, 100, yeah, right? Okay. But if you're the only one doctor and you have 5 or 6 people in the office, it all goes under you. So if my nurse and my front office lady and my 5 different people in the back office doing stuff, if they are eating, it doesn't matter. Whatever they get, that goes under my name, under the Sunshine Act. And you can look all of that stuff up and you say, gosh, Dr. Jensen had $500 worth of stuff being bought for her by the pharmaceutical reps. For the most part, that would be food over time. And that might just be in a year's time, 5 visits. It could be they ordered you hamburgers and a drink and whatever, and that was $100. And then you did it 5 times, there's $500. Those are, I know it sounds like me just being cheap, but for them to come in and buy you a soda, what bothers me sometimes is the reps are not great at their book work, and they know they have receipts, and sometimes they can't remember where the receipts go, but they'll remember they saw Dr. Jensen, and they'll put that receipt under my name. And so a lot of times we didn't accept we just didn't have people coming in and buying us stuff. I'm just giving you an idea. When I was working at a big hospital place, if they just brought in something for Dr. Jensen, it would be under me. So if they said, oh gosh, Dr. Jensen eats protein bars, and they specifically came to Dr. Jensen, sat with Dr. Jensen, and said, oh, I brought you a protein bar. That protein bar goes under my name only, not all the other 8 people split $3, okay? I'm just giving you an idea of how this all works. It used to be where they could send you, so I was in my earlier days, I would love the opportunity to get sent, flown out of Des Moines to Dallas or Las Vegas or Florida, Charleston, wherever it was. I would, love it. Here was what they do. You get sent to a intense, I call it intense, learning opportunity in one day. So they'll fly you out on a Friday night after work or shortly thereafter, and you have a Friday, you eat, you get off the plane and you go grab something to eat, and it's with all the other doctors, and you just basically are standing up eating hors d'oeuvres. Then they have a hotel room, and then you get up the next day, and at 8 a.m. or 7 a.m. or whatever it is, you have these lectures on things. Like I remember one, it was back in the day when Park Davis was, before they got bought by Pfizer, before all of them got bought out. So Park Davis was an earlier one, and they made an ACE inhibitor called quinapril, Acupril. And quinapril, one of the lecture, I can remember it almost distinctly, was in regards to nitric oxide and the vasodilatation and vasoconstriction of the artery. And they were showing us scans about, like, if you ate, they sent you to McDonald's and you had a Big Mac, fries, and a Coke, and you came back within an hour and got an echo, and they could see the amount of constriction. So this whole Acupril was an ACE inhibitor and how it released nitric oxide. So I got an intense lecture series on Acupril, but really not as much about Acupril as all the underlying anatomy and physiology and biology. I loved it. I learned about cholesterol, and I learned about diabetes. And so if a drug rep said, hey, can I send you to to Dallas, Fort Worth, and stay at this is a very common hotel where everybody goes for lectures, for conventions. So it was right out of the airport, and it was, I mean, you're not sightseeing. You could skip the lectures, absolutely, but for the most part, the doctors didn't skip the lectures. Okay, they were all in there. Nobody really wanted to skip them. I mean, you got sent there for a reason, and nobody really wanted to get in trouble. So we all learned, but I was like the note taker, and I wanted to make sure I understood everything, and it was great. And then they would fly you home on Saturday late after early evening, so you'd be home for within a couple hours of wherever your destination was. But that now, I mean, they don't do things like that, but that amount of money to send you could be $1,000. And then that would go under your name. But back then they didn't do that, okay? There was not record. So that was new legislature. Okay. Let's see. Rochelle says, can you talk about the benefits of exercise? I need encouragement to do this regularly. I can't maintain it regularly. Once I get on the treadmill, I put music on, I'm in the zone. That is exercise, it is. But Rochelle, more importantly, I understand that most people do cardio is they do it to lose weight, okay? They do it to, so to speak, burn calories. But you would be better off, Rochelle, finding someone, a trainer, who can teach you how to lift weights. And then you have skin in the game. You have money being spent on a trainer that you need to teach you. So you want to be very specific on who you pick. You don't want somebody who's going to talk to you and tell you about their night before. You want somebody who is going to teach you about muscle groups, how they work, what certain exercises hit that muscle group, and why. You need someone who's devoted to you to teach you. Or you go on YouTube or you Google it and you have AI tell you how to do things. But a lot of times, see, I used to be a personal trainer. That's how I made money on the side. I would, in fact, I used to coach, I used to train people, okay? And the people who really wanted to hire me knew that they were in for it, okay? Because I was intense and I wanted them to be intense. Now, I'm not going to hurt you, but I am going to show you, we're focused. I'm going to show you what muscle group we're working. I'm going to show you how to turn your toes inside, outside, where to put your fingers, over grip, under grip, false grip, whatever the grip. I'm teaching you everything. Those are the kind of trainers that you want. And it's going to engage you and you're going to feel the muscle working. But it is important, and I say this over and over again, muscle is the organ of longevity. You especially need to work your lower extremities, your legs. You are going to need to get off the chair and get off the stool at some point. And you say, oh, I'm never going to have a problem with that. I can get off the stool just fine. Until you can't, until you're old and you have no muscle in your butt or your hamstrings or your quads, and you have no grip strength because you have never worked anything, you've never carried anything, you've never done anything. And it's never too late to start. You can still build muscle as long as you feed it. What do you feed it with? Protein. Protein and fats. Protein is the building blocks. It's not the protein that is building your muscle. It's the amino acids that's feeding the muscle. Okay? All right. It's very important. Rochelle, I mean, it's easy for me to say because I have done it all my life. I started lifting weights when I was 14, I think. I was 14, okay? And I can remember the first guy who I went to the YMCA and he taught us how to work out. This guy was maybe in college and he would come back in the summer and I was just a little freshman in height. And I was in junior high learning because we had freshmen that was still going to junior high. So I was in junior high and he would have, some of the kids, they just didn't stick with it. But I knew I worked out, I took a partner with me, and she was on all of the team. She was a year older than me. So we went together, and it was almost like he was coaching us, training us, and it was just the two of us half the time. So it's very important. I didn't have to pay for it. It was included in my membership, and he was awesome. Yeah, what a nice soul that would do that. Okay, so get off the treadmill, get into the weights. Coco says, hello, what magnesium supplement would you recommend? Well, it depends on what you're needing it for. If you think you're burnt, well, one, are you low in magnesium? Get an RBC magnesium level. See where your level is at, okay? If you are low and you determine that you do need magnesium, you could take magnesium threonate, which is great for your brain. You could take magnesium glycinate, which is great for sleep and lowering body temperature and things like that. You could take magnesium, I think there's malate, orotate, lots of magnesiums. Those are good for your heart. You could take magnesium oxide. That's good for bowel movements. So is magnesium citrate. So I don't know what you're really wanting it for. Let me see, I'm missing. Okay. Kevin says, my doctor has me scheduled for an MRI and I'm on a statin. What do you think? MRI for what? Big Tech says, why would my GFR go from 68 to 58 in a few months? Big Techs, get a cystatin C. cystatin-C. It's more accurate. A lot of times on a CMP, if depending on the lab, a 68 to 58 could be lab error. So I don't know, but I would get a more accurate level. I mean, I'm guessing you're male, you might have eaten some protein, you could have been lifting weights. A lot of things can throw off an estimated GFR. But a cystatin C kind of removes all of the externals and gives a more accurate reading. Also, I would get a urine microalbumin. Just get it on a one-time deal, whatever. But yeah, if you've got new onset diabetes, that can lower it. If you have a kidney stone, that could lower it. There's so many things, Big Techs. Okay. Yeah, they do the same thing for pharmacists. You're exactly right, Big Techs. Okay, hold on. Still doing a little bit of moderation here. Joe says, go Buckeyes. Yeah, when you're a Wolverine, you might not like the Buckeyes very much. And if you're a Buckeye, you might not like the Wolverines very much. And I'm okay with that. I do not take offense. Whether you're a Buckeye or not, I'm still loving the Wolverines, and you could say the same thing, but I would say go blue. Okay. Okay. Logan, I would definitely see your doctor in regards to that, okay? I don't know what is causing your unattractiveness in your face. Yeah, WT, that would be a good one. Magnesium glycinate. Rochelle says, have you heard of berberine? I have. Helping with satiety? I'm not sure. A lot of people take berberine for blood sugar management, but I would tell you, the reason why you are having problems with being hungry all the time is probably because you are eating carbohydrates and eating them frequently. That means they spike your blood sugar, then you spike your insulin, insulin drops your blood sugar, you get hungry, you eat again. It is over and over like a vicious cycle. So the answer is restrict carbohydrates. Coach asks, what is the most common cause of kidney stones? Calcium oxalate. Kevin says, question, I lifted in high school, but now I am 74 and have arthritis on a statin, and I think they want to give me a stent. What is your question, Kevin? Okay, let's keep going here. Hockey Nut says, is this a question? Drops for parasites. They have drops that cleans you out. Oil of oregano works that cleans out your whole body. Okay. Good morning, Kashua, and thank you again for the fundraiser, the donation to the fundraiser. I really appreciate it. Even if it's $1, you guys, it goes to a good cause. I don't support very many rescues. I kind of stick to one or two, and rescue, rehab, and rehome is right now my go-to, and I support them. Until I find out that they're not doing things kosher, then I'll change. But right now, rescue, rehab, rehome, it's just right outside the metro area, and I think they're right now I think they're awesome, okay? I saved 2 dogs through them. Okay. Lavender Ranch says, my ApoB has been high, 130, 112, 102. Who told you ApoB high, 130, 112, 102 is really a thing? What is ApoB? Lavender exercises 30 to 50 minutes daily, but his or her healthy diet ends up in saturated fat, eggs, nuts, coconut milk, salmon. What are some strategies to lower ApoB? Well, I don't know what your ApoB is measuring. Is it measuring VLDL, LDL, IDL, LP(a)? Which of those markers are more elevated than the other? And that will give you an idea of where your ApoB is coming from. If you are eating a bunch of saturated fats, you are down-regulating your LDL receptors. You could be. I'm going to guess that you are eating saturated fats, and saturated fats notoriously down-regulate LDL receptors on the liver. That means it decreases the doors on the liver, so LDLs can't get back into the liver and go through either recycling or elimination. If you lower your saturated fat and increase your monounsaturated fat will upregulate, increase LDL receptors on the liver. So your LDL will drop, and therefore your ApoB will drop. But if you're eating a bunch of carbs, you're going to have a lot of VLDL. Could you still have VLDL with high fat? Possible, yeah, right? But carbs is the main contributor to high VLDL. I don't know what your ApoB is measuring. Just to say my ApoB is high and you need a statin? Nah, I don't go. I'm not in that direction. I don't follow that plan. I want to know your diagnosis. Okay. All right. Yeah, Hockey Nut, I'm sorry, I don't know. I don't study or do any type of educational stuff on parasites, but I would see your doctor if you have a parasite. Okay, I'm just looking through. Okay, Rochelle says, I have coronary artery disease, so I know it's good for my heart. What is good for your heart? Are there cognitive benefits too? Of what? If you have coronary artery disease, that means you have previous injury to your coronary arteries, and you have whatever that injury was from. Was it from high blood pressure? Was it from insulin resistance? Do you have diabetes? There's so many things. And what I would recommend for somebody like Rochelle is to schedule or sign up for a consultation. Get a consultation. Let's go over everything. You can sign up for a consultation by emailing me at ironladydoc@aol.com. Iron Lady, Lady, doc, DOC @aol.com. And we can schedule you for I will send you some forms, you'll sign them, and we can get scheduled for a consultation. Sounds like you got a lot of complicated stuff, and I appreciate you reaching out. Okay. You guys over on YouTube, can you hit the thumbs up? You new ones that just joined. All right, have a good workout, Habanero. We'll see you later. W.T. Henry says, minimize carbs, increase omega-3, and VLDL and triglycerides typically take a dive. Yeah, absolutely. I mean, I've seen triglycerides go down within 72 hours. And VLDL, the reason W.T. Henry mentions the VLDLs is the VLDLs carry the triglycerides. As the VLDL goes out into the bloodstream, it dumps off triglycerides, which is energy. It's 3 fatty acids and a glycerol molecule, dumps it off to the muscles and other tissue that need energy, or it's stored in a fat cell. But that VLDL will go out into the bloodstream, dump off the triglycerides, and as it dumps off cargo, it becomes an intermediate density lipoprotein. After it dumps off more cargo, it becomes a low density lipoprotein, okay? And that LDL, if it remains in the bloodstream, it can be damaged. So we like to get all of its cargo done, all of its, it's the cargo dumped off, and then get back to the liver, get back to home base. Home base is the liver for the LDL particles. Same with the HDL. If the LDL dumped off some cholesterol to tissues, then the HDL picks up remnant cholesterol that was not needed. It picks up remnant cholesterol and it brings it back to the liver. So there's a lot going on. It's a normal biology, normal physiology that's going on in your body, yet we kind of mess it up with the things we do, whether it's eating wrong or not exercising or sitting inside, don't get up. I mean, we really should be getting up every hour for at least 5 minutes and exercising, okay? Okay. Oh, Habanero's not leaving. He's just, or he or she, I'm guessing he is just going to plug in their device and listen while they walk. Awesome. Let's see. KMC says, so fun to see you doing what you do. Well, thank you for your kind words. I really enjoy what I do. And if you guys want to support me, you do a subscription. If you want to send a super sticker or a super chat, that would be great. Looks like some people over on YouTube are kind of being naughty, so we'll just get rid of them. Okay. Yes, Henry also mentions that when you're on a low-carb diet, you have less opportunity for small, dense LDLs. Small, dense LDLs are, and I believe, I did write this down. I wasn't sure, I didn't know Henry was going to bring this up, but a small, dense LDL is an LDL that has dumped off all of its cargo. It's small and dense, and it has a propensity to be damaged by VLDLs bumping into it or anything that could oxidize it. But a small, dense LDL is very susceptible to being damaged. Small, dense LDLs are highly prevalent in a person who consumes a lot of carbohydrates. Now, can carnivores get small, dense LDLs? Absolutely. It all has to do with VLDLs bumping into LDLs and just basically changing what cargo they are carrying, okay? Then a small, dense LDLs, has a chance to get eaten up by macrophages, M1 macrophages, and those turn into something called a foam cell. And a foam cell has been inside the plaque when they do biopsies. But the small dense LDL, this is where I have concerns about LDLs causing heart disease, okay? An LDL particle, for the most part, is somewhere between 21 and 25 nanometers size, 21 to 25, okay? A small dense LDL is somewhere around 18, 19, 20, somewhere in there, 18, 21, somewhere in there. The normal endothelial junction, interendothelial junction, meaning here, okay, the inner lining of an artery is the glycocalyx. And then inside the glycocalyx is the endothelial lining, one cell layer thick. And each endothelial cell is lined up next to each other like this, like tight. They should be tight, okay? An interendothelial gap is the amount between this space right in here, this space. That space is like 4 to 6 nanometers. Very, I mean, nanometer, 4 to 6. So do you think that an LDL of 22 can get through a space between of 4 to 6? No. So it is doubtful that an LDL, big LDL, can get through this space and get on the other side and cause plaque that comes outward into the lumen of the artery. What about a small dense LDL? I mean, it's even 20 nanometers. How does 20 nanometers get through a space of 4 to 6? So I don't think, and you say, well, maybe it went through the cell. Maybe the LDL penetrated through the membrane of the cell and then went through the cell and then out the back door and then started laying down, got eaten up by the M1 macrophages and became a foam cell and attracted platelets and blah, blah, blah. I mean, you guys, it just doesn't seem plausible to me, okay? But these small, dense LDLs, they're still a problem because they're still sticky. But I don't think that they are the ones transgressing between a cell or through a cell. There has to be a receptor that says, hey, small, dense LDL, come on in. We'd love to have you for the party. And you say, yeah, I'm just passing through, and you go out the back door. As if we don't need to use you inside of our cell. The cells don't do that. They just, I can't think that they would just let anything in, okay? So more importantly, I think stuff, so if this is the lumen, I think things enter from this backside, okay? I think they enter from here and make a plaque, and then it pushes inward, all right? There's no plaque inside the lumen, actual plaque inside the, like you don't look through, like people don't go with a little video and see the actual plaque. They see narrowing. They're seeing lining, and they say, how much dye can fit through here, okay? They're not actually seeing the plaque. The plaque is pushing inward, closing this from here to here, okay? So how does debris like platelets and white blood cells and red blood cells and cholesterol get there? How does because cholesterol doesn't, it's carried in particles, LDL, VLDL, HDL, except in a red blood cell. Red blood cells carry cholesterol, okay? And red blood cells can feed into a major artery through tiny little arteries. So every artery needs a blood supply. It is living tissue. You can't just have an artery and it doesn't have a supply. So red blood cells need to feed an artery. They come through littler arteries, and it's called the vasoviscorum. And they feed the lining in the artery itself because it needs a blood supply. Well, if the red blood cells get wiggled through there, these little tiny entryways, these little tiny capillaries, they can get damaged and kind of split open. And then they could dump their contents in this area. right? That's a possibility that they could dump their cholesterol into the area, and that's why we got cholesterol. I mean, I don't know, but I just can't get on board and say LDL's bad. I could give you reasoning why a VLDL is bad, okay? And do VLDLs, if they're high, raise ApoB, and we got this new thing we look for just to get you on medication? We got to know what's going on, you guys. We really got to know what's going on, okay? Sherry says, I had a cabbage, so a coronary artery bypass graft a year ago. So June, 1 year ago, 13 months. My EF, which is ejection fraction, that's the ability to pump blood through the heart. How much can I eject on one pump? Has dropped from 55 when I left the hospital to 31 recently, because your heart is hurting and you had a cabbage, and it will take a year or two for that ejection fraction to come back up. And so a lot of times you go on a beta blocker and you'll go on a blood thinner and you'll go on all these medications that help your heart heal. It's just hurting. You opened your chest up, you dove into arteries, you bypassed them, you're doing a whole bunch of things, and now your heart's going, I'm going to hibernate for a little bit and slow down. Hopefully that answers your question. Again, I'm not a cardiologist, okay? But this is, I think, just simple information that most doctors should know, okay? S. Pern says, does having an ApoB of 1.42, I don't know, I'm guessing that's 142 in U.S. standards, and an LP(a) of 23, an automatic reason to put you on a statin? Well, it could be for certain doctors. They could say an ApoB of 142, yeah, you need a statin. You're going to die of a heart attack. Well, are you? I don't even know what your ApoB is constituting. What's your VLDL and your LDL and your IDL and your HDL? I want to know all of it. I want to know your triglycerides. I want to know it all. I mean, if your VLDL/triglycerides are elevated over 70, they're taking up making a lot of that ApoB. ApoB, okay. I'm pretty sure I have drawn, okay. Every lipoprotein, LDL, VLDL, IDL, LP(a), all of those lipoproteins have a protein on them called an ApoB. We named it. It's a protein embedded on the lipoprotein, on the LDL, the VLDL, the LP(a), the IDL, all of them. On their membrane, there's an ApoB. ApoB counts particles. LDL cholesterol is trying to assume how much cholesterol the LDL is carrying, okay? But every particle that we're counting right now has an ApoB. And LP(a) has an ApoB and an ApoA. So we call him LP(a), okay? Or lipoprotein(a). He's got an extra little protein that makes him an extra little bit more prone to clotting your blood. He doesn't do it all by himself. He doesn't just say, I think I'm going to clot your blood today because I'm high. Not so much. But if there's a scab or an injury, lipoprotein(a) will get involved, and fibrinogen, and factor V, and factor VIII, and PAI1, they all get involved and increase your risk of having a blood clot, which can cause a heart attack, despite having a clean artery. You could have could be CAC score of 0, but a blood clot is a blood clot from an injury, okay? Injured the lining of the artery, a scab was trying to form, it broke off, maybe you got all mad and anxious, and your blood pressure went up, and the pressure and the volume of blood rushed past that, broke off that little clot, and bam. But no, that's the reason. Nothing automatically puts you on a statin. Statins, if I could give you two things why a statin would be beneficial. One, it's anti-inflammatory. Two, it's antithrombotic. But why not just stop the injury, find out what's causing blood to clot on the artery? Why would you take a statin? I'm just saying, why would you take a statin? Maybe you would. Maybe you say, Doc, I'm not going to change my diet. I'm not going to stop smoking. I work around diesel engines and I'm not stopping. I love potato chips and I'm going to eat polyunsaturated fatty acids until I die. Then maybe you take a statin. It will, plus an aspirin. I mean, everybody's got their own scenario. Well, yeah, but I heard about dementia. Well, you're taking that risk. If you lower cholesterol, if you think that cholesterol is your problem, then, but it doesn't sound like you're worried about that. You're worried about your 23 LP little a, which is really kind of fine. I mean, we all need LP little a, or we could bleed to death. But when it gets over 30, 35, maybe we got to say, hey, this is a risk factor. I got too much LP little a, plus my factor 5, plus my factor 8, plus my fibrinogen, plus my PAI1 that was released from my active endocrine fat around my liver. Yeah, I'm a setup. Do you need to take a statin for that? I don't know. You definitely, if you have ectopic fat, fatty liver, you got a lot of inflammation. I mean, a statin could maybe help decrease that inflammation. My thought was, let's get rid of the visceral fat. Why do you take a medication? The medication's not going to help you get rid of the visceral fat. You're feeding it. Okay. Yuli says, how is the new cholesterol drug mechanism working? And is it different or comparable from the ones being prescribed? Oh, so the one we were going to, okay. So I a lot of times where I get daily information in the medical field is through Medscape, not the Medscape like WebMD Medscape, but Medscape that's more for doctors. And it goes through studies and it talks about new things that are out. And one of those things is called an ApoC3 inhibitor. It does exactly what it's going to do. It inhibits ApoC3, which is another molecule in our body. There are some people that have a lot of ApoC3. And there are some people that don't have very much ApoC3. ApoC3 acts in the liver to slow triglycerides from being broken down. If we slow triglycerides from breaking down, they can remain in the liver and choke it. So we want the liver to be able to package those triglycerides up into a VLDL and send it out into the bloodstream to get delivered and dump off its cargo. If you have too much ApoC3, you don't break down triglycerides. Why? What does ApoC3 do that you can't break down your triglyceride? Well, if you can't break it down, you don't have the enzyme to break it down. That is lipoprotein lipase, LPL. LPL works on a triglyceride to break it down and use it for energy. You want to, when it comes out, the triglyceride breaks down into its 3 fatty acids and its glycerol, and then it goes into the cell and it gets repackaged back into the triglyceride. Okay? It's kind of complicated, but if you have less LPL, lipoprotein lipase, you have less ability to break down triglycerides. ApoC3 down regulates, makes less available LPL. So triglycerides build up. These people have triglycerides that are usually over 500. I mean, they could be up to 1,000, okay? So there's a new medicine. I think maybe it's still in phase 3 There's actually two medicines. One is an injection that's monthly, another is an injection that's quarterly. These medicines are mainly meant for people with high triglycerides, okay? High triglycerides. There's the Shasta 3 study and the Shasta 4 study. And again, I think they're still in phase 3, but I don't quote me on that. And this particular medications, injectables, are some sort of an RNA, injection, some sort of thing that they're messing with the DNA. I don't know, the RNA, I guess. Okay, I did not look into the mechanism or what they actually are, but the indication is for triglycerides greater than or equal to 500 and preventing pancreatitis. So these medications, because they're inhibitors of ApoC3, they're going to suppress ApoC3 and allow LPL, lipoprotein lipase, to actively break down your triglycerides. Now, do medications elevate triglycerides? Yeah. Seroquel, Zyprexa, which is mirtazapine, Geodon, beta blockers. The person who was talking about their heart and ejection fraction, a beta blocker can increase the amount of triglycerides. So if your triglycerides were 100, you go on a beta blocker and now they're 150, and you didn't change your diet, that could be the culprit. What about thiazide diuretics like hydrochlorothiazide? That can increase triglycerides. Corticosteroids. What if you end up getting sarcoidosis and you got to be on chronic daily corticosteroids? Or you go get your blood drawn and you happen to have poison ivy and you were taking a bunch of prednisone, that could raise your triglycerides. Thiazide diuretics, yeah. I'm not thinking, but those are some of the medicines. Mostly, I would say, is antipsychotics. Could you have a genetic problem where your LPL, your lipoprotein lipase, is not working very well? Yes. LPL sits on your blood vessel walls and it's breaking down the triglycerides, right? But if you have a genetic problem of LPL, it's called obviously familial. You're going to have high chylomicrons in your blood. You could have high chylomicrons in your blood. There's two ways we transport triglycerides. We transport them through chylomicrons because we've eaten the fatty acids and they get packaged into a big chylomicron from our diet. And then we have VLDLs. They carry triglycerides, and that's when the liver makes the VLDL, packages it up, and sends it out into the bloodstream. So if you have high chylomicrons in your blood, you could have a deficiency of LPL. You're having trouble breaking down those triglycerides. I know it's complicated, and I'm sure you probably didn't even want to get into that. But you can have a genetic problem with your LPL. You could be eating too many triglycerides. You could be taking medications that increase triglycerides. Triglycerides, I believe, are very, very, very atherogenic, meaning they plaque arteries. So it is very, very important that we keep triglycerides under 70. And when triglycerides are low, HDL is going to be high. Our goal is an HDL greater than 70. The new medicine I was referring to is a ApoC3 inhibitor. I did not mention the PCSK9 oral pill. That is another new one. Again, I don't know if that is if it's still in phase 3 or if it's out yet. I don't know. But the two names of the ApoC3 inhibitors is olezarsen and plozasiran, something like that, okay? They are ApoC3 inhibitors, and I thought that's what Yuli was talking about. Again, there is it's not new, it's a PCSK9 inhibitor, yes, but it's oral, Okay? It's oral, and I can't remember the name. I apologize. Back to Nature says, hello, Doc. God bless you for the medical education. What are your thoughts on plant medicine that cures mental derailment like OCD, schizophrenia with plant medicine out there? Well, prevents it? Did you say prevent? Cures. Plant medicines that cure mental derailment. I guess I can't speak to that. Okay? I can't. I want to know, what is the OCD caused by? What is the schizophrenia caused by? I want to know a diagnosis before I give a plant, which most prescription medications are all made from plants, okay? So you're just saying, I'm going to give you hibiscus and I'm going to cure your whatever the ailment is, okay? I have no education in that. That's naturopaths or but my thing is, let's prevent it. Let's find out, how can I prevent most chronic diseases? Diet is a big one, okay? Sleep, sun, no blue lights, don't smoke, don't drink alcohol, all of those things increase our risk of a chronic disease. And now you're asking, well, what if your OCD comes from eating too many carbohydrates and you eat McDonald's and you're eating potato chips and polyunsaturated fatty acids and even eating pasta and cereals and bagels, just to think of these are normal things, and you end up with OCD, or you have, OCD, to be perfectly honest, probably started in childhood, some sort of childhood trauma. Okay? But if you have schizophrenia, could there possibly be a genetic component? No, I guess the answer to your question, I don't know about plants curing, My goal is to find out what is the root cause. You're welcome, Lavender. You're very welcome. Sherry, you're very welcome. They're just thanking me for the information. Okay. Yuli says, thank you for your excellent explanation. As always, we are learning so much here from you. You're very welcome. Yeah, I know, Vicky. They do give beta blockers very rapidly. These are standard of care, Vicky. Everything is standard of care. The doctors may not know they increase triglycerides. The doctor may not know that putting you on a beta blocker could increase your depression or worsen your asthma. They should know, but they may not know. They may not know what a beta blocker is actually doing to the other physiologic aspects. Their goal is, I see post-heart attack, here is standard of care. You get a statin, you get a beta blocker, and usually it's carvedilol. It's not going to be atenolol or one of those, propranolol. It'll usually be carvedilol. Corig is the other name for it. They're going to put you on a beta blocker to help increase heart function. And they're saying, let the PCP deal with their diabetes that they get. Let their PCP deal with their cholesterol medicine. You're right. This is not perfect medicine. There's nothing perfect about this is why I don't practice medicine in an office anymore. It's very stressful. I don't think that patients are getting the care they needed. And basically, I went from downsizing to really downsizing. I downsized from corporate medicine down to opening up my own practice, seeing 14, 15 patients a day instead of 40, 50 patients a day. That was downsizing. You downsize that much, you downsize your salary. Trust me, okay? A lot. Okay? Well, now I'm downsizing even more, where I'm focusing on consultations from you guys that you're scared. Your doctor is telling you you need this, and this. And I'm saying, hold on, take a breath. Let's go through these labs. What is it that's causing this to cause them to say this? See, I can think from both aspects. I can feel your pain, and I can also kind of understand why they're making decisions like they do. And usually it's a protective mechanism. You're granted, they are bamboozled by the buffoonery. They are indoctrinated 100%. We all are, okay? We were taught whatever the curriculum, whoever wrote the curriculum, you know who that is, they wrote the curriculum for every medical school, every medical school. And that curriculum is the same whether you're a DO or an MD. You are taught the exact same material. It might be in a different order, but it's exactly the same for the most part. Then you go out into rotations. So you do rotations. You rotate. You're not out of medical school yet, but you rotate through with doctors. You go to the hospitals, you go to their offices, you rotate, you shadow them, you walk, and you learn from them more. Then you take a 3, 4, 5-year residency where you're now being paid. You graduated from medical school, you have your degree, you're in residency, you are a doctor, you are licensed doctor. You're just a resident, not just, but you're a resident. It's the early stages of going out on your own and being a doctor. You're supervised by senior doctors. And then you learn by doing. You know, you see one, you do one, and then you teach one. I mean, that's what they used to say. You see a procedure, you do a procedure, and then you just go teach a procedure. And it's more complicated than that, but that's the process of our education. And then our CME, we have to do CME, continuing medical education. It's written by the same people who did medical school curriculum. So it's just reinforcing. And we see LDL high, here's your statin. Oh, it's triglycerides, here's your ApoC3 inhibitor. Oh, you got a PCSK9 inhibitor problem? Oh, we got to give you a PCSK9 inhibitor. If you have an LDL receptor problem, here's this. If you have an NPC1L1 problem, here's this. But they don't make a diagnosis. Oh, you got high cholesterol? Here's your statin. Oh, it's not working? Let's add this. Oh, it's really not working? Let's give you an injection. There's no thinking about what your real diagnosis is. From my perspective, I see a lot of you guys saying, well, I said, they put me on a statin. Why? Well, they said my cholesterol's high. Why? I don't know. That is not... Would you let your financial advisor say, I'm going to sell you a bond ladder? Oh, okay. Well, did they mention to you that you're only getting 1%? Well, you can make that in a bank. Did they say that the bond ladder is for a 15-year bond ladder? And did they also tell you that it's being managed by another financial place that takes another 2% or 1%? And I'm also, by the way, charging you 1%. So now that's 2% on your bond ladder? You know, you didn't see, if you didn't know those questions to ask them, you would just say, oh, whatever you think. No, do you just give your money to some guy and they say, or girl, and then they say, I think I'm going to do a bond ladder. I think I'm going to buy them an ETF. I think I'm going to put them in an annuity. And you say, why would you do that? Well, I kind of make money off of your annuities. I get an upfront load. Oh, well, does that help me? Not really, but it really helps me. I got to pay for my kids' college education. You guys, there's every industry, and it's very important that we educate ourselves instead of just trusting people, okay? I don't want to say we shouldn't trust people, but maybe we shouldn't trust people. We don't know what their agenda is. Coco says, hey, hello, me again. Cholesterol 298, HDL 81, triglycerides 81, LDL 198, LP little a 14, CRP less than 1 at 0.4, calcium score of 0, exercise regularly, weights, walking, except for triglycerides. It's really not that bad, Coco. Triglyceride of 81? Seriously. I mean, I don't know what you ate 3 days before getting that lab test, but metabolic is 198. So you're going to, eyeballs are going to start popping out of people's heads. If you want to find out why your LDL is that high, or is it dangerous LDL, get an NMR, a nuclear magnetic resonance imaging. It's an advanced lipid test. Do you have large buoyant LDLs or moderate, medium-sized LDLs, or you have these small, dense LDLs? You already got a reassuring calcium score. The power of 0 from the MESA study says that if you've never had a coronary event, The MESA study says if your CAC score is 0, you don't require medication. Do doctors know that MESA study? No. It's a meta-analysis. It went over a whole bunch of studies, and it grouped them all together. I don't know how many studies. I can't think about that right now. Well, did it say how many? I don't know if I wrote it down. If the calcium score was greater than 0, then your LDL does become a risk factor. Even if it was 1, 2, or 100, the MESA study says that, okay, your calcium score is over 0. Now you're at risk and probably need a statin. But with a calcium score, just so you know what this calcium score, and you've never had an event, you would have to treat 87 people. Let's just say 9. You would need to treat 90 people for 10 years in order to prevent one event. So if you started taking a statin, 90 people of you would need to take it 10 years to prevent one of you from having an event. You have to ask yourself, is that worth it to me? Is that number needed to treat 90? Or my calcium score is 0, the chances of me having anything go on, even if your score is above 190, which yours is, it's 198, okay? But doctors don't think like this. Their standard of care says LDL over 130 or whatever it is, statin. They're not going into, I wonder what the MESA study says about a calcium score of 0, LDL of 198. But again, if it was me and I was your doctor, I would say, hey, Coco, we really need to just make sure that your LDL are large and fluffy. If they're small and dense, we might need to back off. I don't know what your diet, I'm guessing it is very low carb with these numbers, okay? I would say, hey, Coco, we probably need to back off on saturated fat. Let's back off on some of your saturated fat and replace it with some monounsaturated fat and try to get some of that LDL out of there. Your body doesn't process saturated fat very well, okay? I don't know, but I could look into it. But I would just be guessing right now. What test shows it is familial? What is familial? Hypercholesterolemia or a chylomicronemia? You can get an advanced lipid test. And one of the line items will be your chylomicrons. It'll say how many you have. You guys, if you want to support this channel, please subscribe or, help me out. This is what I do for a living, okay? I love to teach, I do, but I also need to pay bills just like everybody else. Okay, subscribe, send a super chat or a super sticker. S. Pern says, thank you for taking the time to answer my question. You're very welcome. Much appreciated. Also, does having an elevated ApoB of 142 mean you automatically have FH? No. There's 3, that's a genetic disorder, and it has 3 genes. Do you have a PCSK9 problem? Do you have an LDL receptor problem? Do you have an NPC1L1 problem? I don't know. But FH, to really diagnose it, which gene problem do you have? They're just saying FH is an LDL cholesterol over 190. You have FH. Well, how do you know? And if I do have FH, it takes a gene panel is what I'm saying. If you really want to know, get a gene panel. Find out which 3 genetic markers, ApoB, LDLR, which is the LDL receptor, or PCSK9. What is your problem? Is it the ApoB of 142? I can't imagine that is it. I would not say, I think, is it Coco? I can't remember. S. Pern. I can't, ApoB 14. You got familial hypercholesterol. No, it's just an easy thing. Your parents had high cholesterol and their parents had high cholesterol. You got something familial. That's not how the diagnosis works. You don't just give FH. That is a diagnosis that says you have a real gene problem. Which is it? PCSK9, ApoB, LDLR, or all 3 or 2 or 1 or, It's called it's called a FH panel. FH panel. Good morning, Sheila. Memel says, how much saturated fat should we target? Is 20 grams too high? No. I mean, there are people who are, you need fat. I'm talking, you could be getting 125 grams of fat. If you get 125 grams of fat, maybe you're 50-50, saturated to monounsaturated. There are people who eat 125 grams of saturated fat and never have a problem. But I don't know Memel and how her body, I can look at your liver function, I can look at a bunch of things, I can look at the size of your LDLs, I can look at your insulin, I can look at your CBC and your CMP and all these labs, and I can make a pretty good decision, okay? But 20 grams, you're basically causing your own dementia with that little amount of fat, okay? We need fat. Every membrane in your body cell membrane is made of fat. You need fat. Okay? For somebody to tell you don't eat any fat, you're going to have problems moving forward. It is an energy source. If you don't eat fat, what are you going to eat in its place? And don't tell me you're going to eat 100 more grams of protein. Instead of 100, you're going to eat 200. I'm just going to replace it. Oh, no, you won't. You'll eat carbohydrates. And then you'll get fatty liver and diabetes. And you'll have a dementia from type 3 diabetes. Okay? So again, think about what you're saying. There is you know what, Memel, go on, when you're on YouTube, watch Sten Ekberg, E-K-B-E-R-G or E-C-K-B-E-R-G. He talks about fat and macronutrients. He talks a lot about, okay, we're going to get this many carbs, this many proteins, this many fat. But again, 20 grams, 20 grams, it's a tablespoon of oil in your mouth. I guess that's 14, but it'll be 10 macadamia nuts. Something like that is 20 grams. That's crazy. Okay, that's very low. Coco says, oh my goodness, thank you so much, doctor. You've given me more info than any other doctor, but you need to look it up, okay? You hear me talking, and what if I don't know the answer either? I'm trying to get you guys just to learn, okay? All right, I'm just trying to get you guys to open up and start using your brain. It's been hibernating. All of our brains have been hibernating because we've just been yes people. Yes man, yes woman, yes, 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 whatever you say. Okay, that's right. Oh, you don't want to use your own thinker. We haven't used our thinker for the last 50 years. We're not using our own thinker. We're being told, and we regurgitate everything we've been told. And so now I'm like going, hey, maybe that is not right. And I need to start regurgitating something else. Okay? Hopefully I answered Vicky's question. What does it mean to be familial? Okay. Oh boy. Trying to get these to move up. Yeah, 20 grams of saturated, Memel, that, okay. 110 fat, 10 grams fat, focus on monounsaturated. But if you start focusing on monounsaturated, just listen, hear me out. Remember that saturated means there's no double bonds in that chain, that fatty acid chain. No double bonds. If there's no double bonds, can you get oxidized? No. Monounsaturated has one double bond. All of that monounsaturated fat and those double bonds, guess what? You got oxidation going on. Then you'd say, oh, I'm going to eat some polyunsaturated fats. I happen to eat some French fries, and now you got PUFAs in your blood. And those have many double bonds. Now you're really oxidizing. So do you want 110 grams of monounsaturated fatty acids? I'm not so sure. There's a lot of oxidation going on, a lot of damage to those double bonds. It can be, oxygen can bind oxidation and cause damage, rusting, damage. Okay? So I don't know what the answer is. I haven't looked at your labs if you want to do a consult, but I just want to caution you that there's nothing, the doctor could say, oh, go on a monounsaturated Mediterranean diet, and then you end up having a heart attack because you don't sleep well. You're a stressed out person. You're under blue lights. You never get up. You might exercise for 20 minutes a day. You've got a lot of oxidation. And they say, I don't know why I told them to follow the Mediterranean diet. They probably just had a bad gene. Okay. Yes, if we're not, yes, we get mistreated and abused by doctors. I understand. It is easy because doctors hold themselves at higher levels than anyone else because they say that you deserve it. I deserve, because I went to medical school and spent $200,000 in debt, that I deserve for you to listen to me. If you don't listen to me, you will die. I think every doctor goes through that thinking process that, okay, you don't want to do it? Go somewhere else. As if they know everything. Okay? Their ego speaks louder than anything else, and they feel they deserve it. Anybody who has higher education feels they deserve because they spent hours of turmoil and misery and money. And it is not an excuse. I'm not saying that this is an excuse. I'm just saying that this is what develops, okay? At first, we start out saying, I just want to help people. And then when you get done, you don't even know I did not know what I was in for, okay? How many hours I had to study, going into the dirty labs, poking on dead people. You I let Buddy down, and he's not potty trained yet. He was wandering. Come on up here. Come on up. And so, again, we go into it with certain intentions, and by the time we are done, it gets a little more complicated, okay? It's a little more complicated. I'm not giving me an out or any other doctor, but you have to realize, Vicky, that we all put our clothes on the exact same way. We all sit on a stool and have bowel movements and urinate the exact same way. There is nothing special about me except that I used to wear a white coat and dress up and wear jewelry and do all these things, and you hold me at a higher standard. You hold me at a standard because I've read a textbook. Now, granted, you would hope that I read the textbook, I understand the textbook, and I can regurgitate it back to you. But instead, we made it our information and we kept it to ourselves. And we would say, we have the textbooks, you do not. You can't have access to them because, one, it's really prohibitive as far as money is concerned. You're not going to go buy a textbook, read it, and try to understand it. So we kept that all from you guys. Subconsciously, but we did. Because we felt superior to you. But now you guys have medical books at the ends of your fingertips called Google. And you can Google it, but then you bring it to your doctor, and because of their brain, they're saying, I know more than Google. You need to keep that to yourself. You either listen to me or you say bye-bye. They were offended. So you can't talk to them, and they will mistreat you. And it's not really a mistreated. It's just making you feel like you're small. I'm the one that's educated. I'm the one that makes the money. I'm the one that had to go to medical school and do all the things. We chose to, by the way. You could say that, doctor, you made a conscious decision to go into misery. Just like I chose to walk around picking up cans in 117-degree heat for my income. You chose it. Why should I have to pay for you choosing your thing? Why do you have to be mean to me? Why do you have to make me feel small? We all do it. Okay? I'm not saying it's right. I'm saying it happens. And that's why you need to continue to educate yourself and stand up for yourself. If that particular doctor is not the right one, and you say, Dr. Jensen really doesn't do that to me. She doesn't make me feel like I'm small, but she does make me, I'm a little intimidated by her many times, and I really don't want to disappoint her. It's not me you're disappointing. You should be disappointing yourself. Whether I intimidate you or don't intimidate you, I'm going to give the reins to you. I'm going to educate you the best of my ability. If you say, well, Dr. Jensen, what if it's a parasite? And I said, we better look into it. The parasite's increasing my LDL. Well, why do I have a parasite? Well, what are you feeding it? A parasite has to live. Do I know anything about parasites? No. I mean, not really, right? Do we know anything about viruses? No. Bacteria? Not really. Fungus? Maybe. I don't know. Well, here's your medicine. That's all we'll say. But you say you treat it, you get rid of your candida, and then it comes right back. Why? Well, did you check for diabetes? Well, no. Well, what are you eating? I don't know. I just eat whatever everybody else eats. See? Yeah. I'm sorry that you were abused by your doctor. S. Pern says, if I am presently on a PCSK9 inhibitor, the FH panel lab outcome, you would need to actually go off of the PCSK9 in order to get an accurate level. I hope that's your question, but I don't know. But I'm guessing that was your question. Mimel says, generally what proportions of short chain fatty acids, medium chain fatty acids, and polyunsaturated fatty, well, I don't know that there's ever a good PUFA, okay? If I want I don't, again, I can't really determine how your body handles saturated fat. I don't know. I don't know. Like I said, I could have people eating 200 grams of saturated fat by ribeyes, New York strips, eggs, butter, and their LDL is 100. And then I could give that same food to Mimel and your LDL is 500. I'm going to say, yeah, your body's not handling that very well. And then we back off. Maybe we go to 75-25, then we go to 50-50. Maybe we have to go to 75 monounsaturated and 25 saturated. I don't know. So I can't really give you a general, but I think in general, people don't eat enough fat in general, okay? And so we need fat. Now, if you're 150 pounds, you might need 125 grams of fat. Now, how we divide it up is up to how your body handles it. Mary says, I don't know how many times I've been told I'm going to die as I will not take statins. Well, I'm still here in my 60s. There you go. Hey, Lucy, thank you for being here. I think everything has been calm, but I appreciate even for your little bit to be here. Yeah, Henry, I'm not sure what you're talking about. Antihistamines, old antihistamines, newer generation antihistamines. I missed the question. So you must be talking to someone. Does taking creatine cause any damage to the kidneys? Likely not. You need creatine for your body to work. Now, there could be other problems with your kidneys, and your GFR needs to be evaluated, but every time you eat meat is healing. Your kidneys are likely gone bad because of carbohydrates, not from protein. Henry says, the Malcolm Kendrick theory, plaquing from the outside as opposed to the conventional view of plaquing from the inside. Yeah, if you guys, Henry's speaking to a book, it's called The Clot Thickens, not the plot thickens, the clot thickens. And Malcolm Kendrick is the author. His son, by the way, actually came up with the title of that book because it's all just like hearsay or it's theory. We're going to just think of something. We're going to hypothesize. Could it be something else? And Malcolm Kendrick has come up with something else, a thrombogenic hypothesis versus a lipid hypothesis. Maybe it's a combination of both. I think it is. If you have bad LDLs because of what you're eating and how you live, yeah, that is going to play a role. Trust me on that. So it's maybe a combination of thrombogenic and from a lipid, the lipid hypothesis, a combination of both. Okay. What's your doctor in? I don't know what that question is. Oh, yeah, I'm an osteopathic physician. I went to a DO medical school. I took an MD residency and I took MD boards. Yeah, Henry, right on. Don't get mad. It's very bad for clotting. Absolutely. One little spell of being angry and bam, you are, yeah, having a clot. It actually releases clot-forming hormones when you get angry or feared. It has to do with your sympathetic nervous system. And yeah, I agree. Don't get frustrated. I could sit here all day and talk to you guys and rattle off everything I know, and we would be talking till next week. I'm not trying to like explain all of this stuff in days. For those of you who come here every Saturday and Sunday with your questions, you're learning a little bit at a time, a little bit, and a little bit. And then during the other times, who's going out? I'm going behind the scenes. I'm reading, I'm learning, I'm listening, and a little bit, and then I can put it into a big picture, and I connect a lot of dots, and then I help share it with you, and then we're all wrong, and then you guys tell me, hey, Dr. Jensen, I think you missed this, and then we go look it up together, and it's one big giant journey. I'm behind the scenes helping you guys, maybe encouraging you to read up on something like maybe reading that book, The Clot Thickens by Malcolm Kendrick, and saying, hey, could there be something else? And then maybe you read Nina Teakoltz's The Big Fat Surprise, and you say, maybe we've all been bamboozled. Maybe this is all one big giant conspiracy and somebody's trying to whatever. It's all possible. Until I go with Jesus, I'm not going to know the answer. All I can do is try to help you guys right now, try to open up your brain and think logically, okay? And not giving in to just somebody's whim and their ability to make money and to protect themselves from getting sued, i.e. doctor. Henry says, I just started this education journey a year ago by consuming a lot of YouTube cardiology and lipidology and feel fairly comfortable now with the content. In other words, Henry can listen to what I'm saying, and because of his education over a year's time, he's able to connect some dots, and that's awesome. Okay. And then Henry can go and coach ask the question and say, Henry could answer the question or at least come close. Okay. Phyllis says, Dr. J, you're such an amazing person helping us understand the maze of our health. Yeah, I'm learning too, Phyllis. We're all on this journey together, just trying to learn. What are your thoughts, Countess says, Nina, what are your thoughts on getting a DEXA fit, RMRVO2 test? Need to build muscle and lose fat, never lifted weights, older, thanks. It's up to you. I mean, do you want to spend money and somebody tell you that you are not processing the oxygen, you're way out of shape? Getting a DEXA scan, I think that's what you meant. I mean, maybe you want to know what your fat content is inside of your body. I mean, I guess I would want, if I could afford it, or if I just had an interest, maybe I want to say, hey, you got a lot of liver fat here. And then you recheck it in maybe a year and you say, oh, I got less fat around my liver. If you like that kind of stuff, then get it. Should you get an NMR? Yes, I think you should get an NMR. Leslie says, I can honestly say I feel better just hearing you. I would like a consult. Just email me at ironladydoc, IRONLADYDOC at AOL.com. And I'll send you some forms you can read and decide if you want to follow through. Vicky says, sadly, all these things are too complicated for us to comprehend who's right. I agree. It is very complicated. I get overwhelmed just like you do, okay? I am no different than you do. But I just keep at it and I keep at it and I keep learning and I keep reading and I keep saying, oh gosh, I wish I could just ask you a question, and I can't, sometimes I want to say, Dr. Bickman, I wish I could just ask one little question. You said something here. It's like, yeah, and it's hard. It is hard. So I get your frustration, but just stick at it, okay? I don't know who the right doctor is for you. It's, you got to be careful with AI and Google. They're going to feed you information. I now have enough information that I can get away from how AI wants to direct me. AI wants to direct me to standard of care, always. But because I know more, I'll say, yeah, but what about, oh, Dr. Jensen, that's a great point, or whatever, however they say it. You're using your analytical, functional knowledge and blah, blah, blah. Then I walk them down rabbit holes. But a lot of people don't know that. They'll just look up something and they'll say, it'll just give you standard of care. Go on a statin, you're gonna die. Katie says, my naturopath thinks differently about creatine. She has seen many of her patients' kidneys be severely affected. Can you say a few words about thyroid, T3, T4, reverse T3, and leptin? Appreciate your science learning. Give me an idea. What is your question? Just for me to talk would get me, just talking and babbling. Thanks, Vicki. I appreciate your support. You're welcome, Leslie. Okay, Mary's got to go. Thank you so much. Appreciate you. You're very welcome. Henry says a low-carb diet has shown a lot of positive impact on mental illness such as schizophrenia. Absolutely. So if you want to look at Dr. Georgia Eade and Dr. Chris Palmer, it's called The Metabolic Mind. You can go to their website and there's lots of articles, lots of videos. The Metabolic Mind. Dr. Brett Shear, The Metabolic Mind. It's really good. There's a lot of good information. Joel says the SEC is going to win the Natty this year. You think? No Big Ten, nothing? Okay. Okay, you guys are talking football, I'm guessing. Neil says, I can't believe I've managed to catch you live. I'm on holiday from Western Australia and England. You're fantastic. And it must be about 6:00 p.m. there, right? North Dakota, Doc. What are you eating? You're eating your toenails. Oh, buddy. We have an appointment for those on Thursday, okay? Yep, they're going to trim them all down for you. I don't know why you want to eat your little toenails. Lance says, Doc, you're doing a benefit to all by getting away from the corporate structure and getting out on your own. We need more docs like you. There's not, Lance, there's absolutely no money in it. When you come out of medical school and residency and you owe $200,000 from undergrad and medical school, all you think about is paying it back. All you think about is getting on the cogwheel and making the money. Yeah, I'm sorry, but there is no money. You can barely make a living on your own unless you're doing a bunch of procedures and doing a bunch of blood work and doing a bunch of things that may or may not look legal, okay? And it's very hard for someone to say, yeah, I could make $350,000 here, but I think I'll choose this and make 50. That does not go through a doctor's mind because their status is linked to their income. The more money they make, the higher their status. So, oh, you're just a family care practice guy? I go to the surgeon. I go to the endocrinologist. I go to the blah, 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 the specialist. You've been bamboozled thinking that all of your body is just little 12 parts. It's an endocrine part, it's a respiratory part, it's a cardiology part, it's a dermatology part. You got in your head that you got to go to all these special docs. They got you into that. There is no such thing as a gynecologist, a urologist. But now the urologist doesn't know cardiovascular stuff. I'll give you just this medicine. You go to your PCP if they want. So your PCP still has to know it all. Well, your beta blockers are interacting with this, and this is causing that, and that's why we need more asthma medicine. That's why your diabetes, because the doctor gave you a statin, and on and on and on. Do you see what I'm saying? We got bamboozled by the buffoonery. We allowed it to turn in the direction it's turned. And you guys are the ones that give us the status, okay? It's true. We don't have status unless you give it to us. If you act small and act intimidated, you just pumped us up. Anybody that comes into your life, okay? Doctors don't just get status and they're just going to walk around. They have to have people coming to them to give them the status, the money. Okay. Can you tell us exactly how a doctor gets paid to understand where we need to be careful? Well, most doctors get paid by insurance companies. You guys have insurance. You buy insurance, so the insurance company will pay your doctor for the visit. In the meantime, you pay $1,000 a month to go to a $100 appointment visit once a year, okay? But you buy that insurance to ensure that if something were to happen to you and you went to a hospital, you wouldn't be out $300,000. So a doctor sees a patient and then makes a chart note. It's called a SOAP note, makes a chart note. And then we give you a diagnosis and a code, like upper respiratory tract infection or hyperlipidemia. We give a code, it automatically populates it, usually. We give a code and then we send that code through a billing company or our own billing company, and then they send in what we charged. So every level of service, level 1, rarely, it's just a nurse. 2, you got a little foot fungus, here's your Lamisil. Level 3, you got a cold and a fever, you got a little bit of blood pressure today, that's a level 3. A level 4, oh my gosh, you got some diabetes, you got hypertension, hyperlipidemia, you got 3 it takes my brain to have to think about what I'm gonna do, it takes some logistics. A level 4 is, okay, I'm gonna get paid more for a level 4. So I'm gonna get paid if I document all of these bullet points in my chart. That's if they get audited. But for the most part, I send in my level 4, you got the blood pressure, I had to make a decision on that. You got some cholesterol, I had to make a decision on that. You got some diabetes, pre-diabetes, had to make a decision on that, level 4. Then there's a code for a wellness exam. Do I get paid for a wellness exam more than I would get paid for just a regular visit? Absolutely. I get paid more by doing a wellness exam on you. The code is worth more money. So if you come in and you say, I don't know why my doctor can't fit me in, because they're doing wellness exams. They would rather do a wellness exam and get paid $100 more. They could see, I mean, you're worth like 2 people when they do a wellness exam. What are we seeing you for? Oh, I just want to follow up on my cholesterol. Okay, we'll see you in 6 months. What are we seeing you for? I need a physical for blah, blah, blah. We got a spot here in 2 days. Can you be here at 10 o'clock? Yep, I'll be there. Right? A pre-op physical, more money. So we send in these codes and then the insurance company will reimburse us. All the codes are worth the exact same amount of money. So let's just say a level 2 is $25, a level 3 is $50, a level 4 is $100. I'm making this up, okay? But if you're with a big corporation, your level 4 could be worth $200. A level 3 is worth $100. Me, I'm this little person, right? And they can say, you know what, Dr. Jensen, you're kind of a drop in the bucket and you're not worth as much because I don't have any corporate, not lobbying, but making friends with the insurance companies. It's just me. They say, you know what, you're worth $50. Whereas some hospital organization might be worth $100. So I send in my level, I get my reimbursement, and then I have to pay everybody, okay? There's also something like when you're in the corporation, there's something called RVU, Revenue Value Unit. Each level 4 is worth, say, 10 units, and every level 3 is worth 30, and every 2 is worth 20. And they add up all those RVUs at the end of a quarter or a year or whatever, and they'll say, ooh, you're the highest paid one. You charge the most. Wow, you're great. You're seeing all these level 4s. Your RVUs are very high. you get paid more. Okay? Revenue value units. That is how we don't get kickbacks. There's not like the pharmaceutical companies aren't paying us unless we work for them. Insurance companies don't really give us kickbacks. What they do tell us is if somebody has a cholesterol, if Vicky has a cholesterol of 130 and you don't put them on a statin, they could not pay you as much. You get downgraded. Let's say you have diabetes and you put them on metformin, but you didn't put them on a statin. They're going to come at you and say, hey, we saw that you have Vicky diagnosed with diabetes. You put her on metformin, but where's her statin? You did not put her on a statin. Please consider putting them on a statin. Well, and you say, well, they didn't want to be on a statin. You don't have to answer them back. That's just but in the meantime, they're not paying you as much. And you kind of fail at their standards. So if you have all of these high cholesterol people and none of them are on statins or cholesterol lowering medications, you kind of don't look so good to the insurance company and they can kind of not pay you. But if you follow the rules and if your whole corporation, your whole clinic is following the rules, then you get bonuses. So the insurance company says, ooh, good job, Urbandale Clinic. You're doing awesome. And now your doctors get a $10,000 bonus for following all of the guidelines. Everybody who's on a blood pressure medicine is on blood pressure. You got blood pressure problem. If you got diabetes, you're on a statin and a diabetes medicine. If you got high cholesterol, which they make the rules, then you get this and this and this. Okay? That, I guess, is what you're asking. Here, hold on. It's, I know, Henry, when you say doctors practicing medicine, I get it. You put that in quotes, air quotes, whatever, but yes, it's called family practice. It's called internal medicine. It's called family medicine. We don't practice. I mean, are we practicing? Yeah, you're practicing your skills, I guess, but everybody does. If you're a financial advisor, you're basically got to practice. You learn as you go and you made mistakes and then you try to fix the mistakes. They're all practicing. At some point, your garbage guy says, I could have carried 2 bags at the same time, but if I don't use 2 hands, one's going to spill out. Well, you practice. You had to practice carrying 2 bags to the dump. It's all a practice. So are you going to get scared of your garbage guy dumping? He's got to practice. You got to practice. You see one, you do one, you teach one. Everything is a practice. We don't know it all. You just don't go to school and then you learn and everything, and then you don't need to relearn or do anything. We practice. You learn. It's a journey. No, we haven't talked about lipedema before, Sarah, so I would have to read up on that. I'm guessing it's a low-carb diet would be very, very beneficial, keeping insulin levels low. And I'm guessing these people also have depression. Coach says, how do you beat type 2 diabetes? Restrict your carbs. Madhav says, when I'm 98 kilos, so say over 200 pounds, whenever I walk, I get back pain. Well, maybe it's your shoes. Maybe you have knee pain. Maybe you have something wrong with your hips. Maybe you need an x-ray of your back. Do you have scoliosis? Do you have something going on? So go to your doctor, Madhav, get some x-rays, get an MRI, find out what's going on. Yep, Henry, you need to consider talking to me on a consult and we can maybe figure things out. Why did you go from 150 to 196? So you just go and take some medications. You don't even know what was going on. You don't know yet, but you took 2 medications for a 196. 196 all large buoyant ones or 196 small dense LDLs? I know, Kevin. What do you do with this information? Just keep learning. Then you'll find out. It'll all come. Patty says, is 40 grams of protein daily enough for a 72-year-old woman? No. You need even more as we get older, because you cannot break it down. Not like you were when you were a little kid. You could eat pizza and extract the protein from the hamburger or the pepperoni. Now you're going to need quality protein. You cannot, your body, because you get older, you need even more protein, because what you do eat, you're going to need 20 pepperonis instead of 5 that are on your pizza in order to get the amino acids that you need to extract from that. Okay? So you need more. 40 is like nothing. You didn't miss anything, habanero. No, you actually missed a lot. You should go back and re-listen to it and share it. And everybody hit the thumbs up. Holden says, why is the lymphatic system never talked about at the doctor's office? How does, say, fat affect the lymphatic system? They don't talk about it because they don't know about it, okay? But they should. Whenever we eat fat, our body has to package that up, okay? We package it up into a chylomicron. And then the chylomicron is sent into, so the fat is fatty acid and glycerol, triglyceride, the fat, the energy that you're eating, okay? So that triglyceride, the fatty acids and glycerol, once inside the chylomicron, are a triglyceride. So then the chylomicron dumps it into the thoracic duct. And then once inside the thoracic duct, it drops into the blood system. If there's something wrong with your lymphatic system, yes, you probably could get a backup of chylomicrons. Could it be familial hyperchylomicronemia? Well, maybe, but no, hold on. I'm just going to speak for myself. It's called a condition of ignorosis. Osis means condition of. I have a condition of ignorance. I don't know. I don't know why we don't talk about the lymphatic system. I don't know why I don't know about the lymphatic system as much as I know about the hematopoietic system, the blood system, or the respiratory system, or the heart system, or the whatever system there is, gynecological system. Maybe massage, maybe special types of massage, Sarah, maybe different things where you're getting your lymphatic system going. I can't remember who talks about it, but, I don't know about, sleep and how that affects it. But there are doctors who talk about the glymphatic system up in your brain and how when we're sleeping, we're clearing out toxins and all of that. But yeah, you're right. You're right. I don't know what else to say. You're right. We don't know enough about the lymphatic system. That's all I can say. Henry says, I have thoroughly enjoyed hitching my wagon to Dr. J's health wagon train. Thank you. Yep, Dr. J's prescription for health. Henry says, ChatGPT has helped me, but a lot in my coronary artery disease journey, but it will push recommendations of standard of care pharmacia. Yep, I agree. Let's see. Kevin says, so what to do? What to do about what? I see you have a question, but I don't know what your question is. Mr. Zadia, drop you a super chat and you could show them? Yeah, you're welcome to do a super chat. I would appreciate that. Henry says 196, large buoyant, small dense LDLs below LabCorp lower limit of 90. After or before the Livalo and Yerzetia? Is that where you're at now? So Vicky says, so the more sick we look on a piece of paper, the more money they make? Yep. As long as my documentation and the bullet points meet the level, I could turn your cold into a level 4, if that's what you're asking. Yes. I can make on paper you look really sick with your stuffy nose. Okay? Now, are there doctors that do that? I'm sure there are. And a lot of times, these doctors are getting audited frequently by insurance companies, okay? Now, I personally don't want that risk. And I don't have any really to back me up. When you work for a hospital group in a big clinic with a bunch of doctors, there's people working at their desk doing clickety-clack work, defending all of the things. Okay, they're the ones having to go through and say, why did you do a level 4 when they just had a cold? Well, then they got somebody back there defending you for your documentation. Well, they had a fever, they had a little bit of diarrhea, and you say, yeah, it was one little squirt. But they gave me a level 4. Yep. Well, it was only a day, and I think I ate something bad. It doesn't matter. It doesn't matter. As long as I can document that you had complications that I had to think through, like, okay, what am I going to do about the diarrhea? It was only one day and it squirts, but it's over. Well, but I could say that, you maybe need to increase your fiber in your diet and blah, blah. I could make it up. Vicky, I don't know. I could make it up. But I mean, for the most part, I don't know. I can't speak for other doctors. Do I do stuff like that? Never have. Do I know it's been done? I've seen it. I've seen other, Mr. Zad, thank you. Did you have a question behind that? Thank you for the super chat. Super chat, thank you so much. Or super sticker, I can't see which one it is. Phyllis, Dr. J is here to inform us about our health and ask the questions. It is up to us to do our deep diligence. Yeah, we have to do homework. Everybody has it. We cannot just let somebody tell us what to do. We have to use our own brain and make our own decisions, but we can't make decisions without enough information. It's going to conflict. Everything isn't going to go your way. You can't just say, I'm just going to hang out with people who only think like me. Well, then you'll never learn. Okay? I mean, I might say, I raise Buddy Blue this certain way, and I think it's the right way, but then somebody comes up and says, hey, I really think you should consider doing Buddy Blue this way. And I'll say, I'm only going to hang out with people who think that Buddy Blue's being taken care of my way, and they all do it my way. No, then I don't learn anything. So unfortunately, I might have to go through some turmoil hearing you on how I should be taking care of Buddy Blue when I think I can do it all my own and do my thing, and he's going to be fine. Does that make sense, you guys? Yuli says, so by following the standard of care and prescribing medication to treat the symptoms, you lower the risk of major event that could cost the insurance company a lot of money. Maybe, but the insurance company's in bed with the pharma company and the food company and on down the line. So if I'm the food pharma, blah, 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 I'm giving you the food to addict you to eat it. And then I also own the medicine that will lower LDL that we've been told that you only have heart attacks because you have LDL that's high. So I'm actually the maker of everything. And the food, the pharma, the this, they're all in this little hub, okay? And they all kind of, I don't know, are they whispering to each other? Are they sitting down having coffee and saying, well, we really need to make money on ho-hos and potato chips and Doritos, and then we're going to convince the people that they need to eat a bunch of plants and eat them raw so we can get oxalates, and then we can have kidney stones, and then you're going to go to the kidney doctor. And I mean, it's on and on and on. You could go down 1,000 different rabbit holes. But the insurance company got the money behind them because they're being paid by a pharma company to put their drug on formulary. And then the insurance company is saying, well, everybody should be on a statin. They don't get money for the people being on a statin, but they're following standard of care that was made up by whoever. I mean, it's like you got $100 and you're moving it from the right pocket to the left pocket and say that you lost $100. You didn't. A lot of things go on, you guys. It's a complicated, I don't know it all, okay? But now we're getting to a medical question. What do you think about K2 for high calcium score? I think K2 is important. You should get it through your food. Like maybe you should eat sardines, or you should eat lamb or lard. Take using lard as your fat source. K2 helps to manage where the calcium is being deposited. You don't want to deposit it in your bloodstream. You want to put it in your bones and teeth. And K2 is very good at that. By the way, if you go on a statin, that K2 is being formed on the mevalonate pathway. If you block the mevalonate pathway with an HMG-CoA reductase inhibitor, it's inhibiting HMG-CoA, so now you don't get an end product called K2 or CoQ10 or vitamin D or cholesterol. You've blocked the pathway. Oh, well, just take K2, but you need a statin. Why do I need a statin? You have high cholesterol. Why do I have high cholesterol? It doesn't matter. Take the statin. Okay? While on blood thinners after having a stent, it's not going to hurt you, Vicki. It won't hurt you. But the calcium, you already have a stent. You're trying to get rid of the calcium. Why did the calcium build up? What in your 70 years caused a buildup of damage? What was the damage? Did you remove the damage? You have a stent. Now you have a piece of foreign object in your artery that is going to calcify on the ends. You're taking a statin, or they told you to take a statin, for antithrombotic and anti-inflammatory, because inflammation at the tip of that stent is going to lead to more injury, attracting more debris like platelets and white blood cells and red blood cells and all of that stuff. It's just going to do it, okay? At the end, once you have a stent, you're at risk of a second stent and a third stent and on and on and on, okay? They don't, and honestly, did you really need the stent? I don't know. I don't know. But did somebody just go in, they do an angiogram, they say, oh, I got lumen narrowing, bam, here's your stuff. But what's causing the lumen narrowing? A lot of questions. But it's easy to get feared. When it's in the moment and you got fear and sympathetic nervous system fight or flight, it's hard to make decisions. All I can say is that maybe before going in, you do some research. But like I said, I mean, if I had chest pain right now, I'd go to the hospital, right? And then they take me to the cath lab and they say, you need a stent. In your immediate thinking, you don't think. You just go, okay, do it. Just open it up. I don't want to die. That's what our thinking is. But is it really that narrow? Or is it something like they say, well, it's like 50%. Let's just put the stent in since we're here. It's a procedure. I get bucks. I don't know what they're thinking. But I want you to think through all of those things. Okay? Thank you, thank you, Mr. Zadie. Thank you. Henry, K2's in a lot of different things. There are people who take supplement K2 as well. It is a component of MK7 and MK4. One is like stays in your system a little longer than the other. But for the most part, here's the thing. Henry, if a person has insulin resistance, they have diabetes, no matter if you take K2 or you're making K2 in your body, you have to break down the K2 in order for it to work. And if you have insulin resistance, my battery is going dead, you guys, on Instagram, so I don't know why. Let me see if I can plug it in. Let me see. Yeah, I don't know how it got down that far, but maybe I didn't charge it and I thought I did. I apologize. But if you have insulin resistance, you kind of lack the components to even break down the K2 into its usable form. Okay? Say MK7. I can't remember which one. I would have to look it up. But insulin resistance blocks a lot of normal, optimal biologic and physiologic processes in our body. Okay? So that K2 that you take externally, if you have diabetes or insulin resistance, the process of breaking that down is not, so you want to take the basically the breakdown product already, or else you're going to have, or else you just can't break it down. I don't know. Get rid of the insulin resistance is my only thing. Get rid of it. Yuli says, and this is why doctors have no time to get to the bottom of why symptoms. They don't care about why. That they've never been trained in the why. They've been trained to make a diagnosis. They make a diagnosis and they give a medicine. And then they pat themselves on the back, and the insurance pats the doctor on the back, and all is good. It is not, doctors don't think anymore. They don't go home and go, I wonder why that person has blood clots in their legs. They don't think anything like that. They're going to say, I got a blood clot, here's your medicine. There's no thinking. The only thinking that goes on is, I need to make a diagnosis. So I need to think, what could that diagnosis be? Put the dots together. Oh, I got a diagnosis. Here's your medicine. Oh, it's the wrong diagnosis. Well, you come back. At first I told you your cold was viral. Well, I guess I made the wrong diagnosis. Or it just worsened. So we just re-give a different medicine. We never say, oh, I got it wrong. No, you say, oh, well, it must have just gotten secondarily bacterial infection. Here's your medicine. Come back if it's not better. It's a crazy world. Yes. Yep, we are set up to follow standard of care, and we are set up to get you guys to goal. Who made up the goals? Your guess is as good as mine. How can I prevent an aortic aneurysm from getting bigger? Manage your pressure, your blood pressure, okay? Manage your blood pressure. The higher your pressure, the faster that aneurysm could increase, okay? Does Leqvio block K2? I don't know. Don't get a statin. They put me on Leqvio, and I got a stent because they said the RCA was 95% blocked. Was there any collaterals? Do you know? Um, 1910 says, my pal had insulin resistance, would nap an hour at lunchtime. She started working for the VA, only got a 30-minute lunch, started walking in the sunshine at lunch, and her fasting insulin improved. Imagine that, huh, 1910? The power of nature. Lynn, I don't do requests to be in videos. Vicky says, I was working 60, 80 hours in a week under a lot of stress, was eating some chocolate and some unhealthy foods at work. Also, there was a lot of stress. I had to stop working. I'm 59. Maybe that's the best thing for you. You know, Vicky, if you're the hypervigilant type of person, then, you know, your health is going down the wayside, and no amount of money to die at 60, you know, and live miserably till you're 70, you know, there's a lot of decisions to be made. And maybe your job, you would be much better working at a garden place and talking to people about growing flowers. And you have to say, but I can't live the way I live right now. Then downgrade. You know, but your health is when you're stressed and hypervigilant and you're not sleeping and you're working 60 hours. I don't know. We've kind of all been in that. You're welcome, Crystal. Again, I'm not well-versed when it comes to aneurysms, okay? Yeah, thank you for the super chat. Do you have a question, Mr. Zadie? Do you have a question for the super chat? What is your super chat question before we sign off here today? Oh, yeah. Okay. Now you know. Lynn, you now know. I probably have pushed that button before, not knowing what it was. Okay. you guys, unless Mr. Zadie comes up with a question here real quick, then, but yeah, Mr. Zadie gave it's $2.78. So thank you very much. Everything adds up, you guys. You say, couldn't you give more? It doesn't matter. He gave $2 and everybody else gives $1. And if I have 1,000 people give $1, then you have $1,000. It all adds up. And I appreciate it. You're very welcome, Evelyn. Okay, you guys, before you go, if you haven't clicked the thumbs up, let's do so. In Lord willing, next Saturday, I will be back. Okay, I will be back at 9 a.m. Central Time. Saturday. Every Saturday at 9 a.m. Central, every Sunday at 10 a.m. Central. And we'll come up with the topic of choice. Today, somebody asked about bundle branch blocks and triglycerides. So we talked about those things. And next week, we'll think of something else. All right? I'll come up with a topic unless you guys email me or message me and say, please talk about this. And I'll decide. I might not know anything. And then I'll go, ooh, I don't know if I want to talk about that. I don't know anything. All right? Okay, you guys. Have a blessed, blessed, blessed Sunday. And Lord willing, I will see you soon. All right. Later, guys. See ya.